Set up a pain clinic and practice as pain management specialist. This article has nothing as we thought of setting up as a pain clinic like we do it in hospital. It is about pain, its importance, its current challenges, what anesthesiologist faces, modern pain clinic, relief clinic, then modern techniques of pain relief, what are the problems peculiar to our society, what are the strength of anesthesiologists, what are the weakness of anesthesiologist, and problems of private practice, and need of further education, need of further experience. So it has nothing what we thought it would be like. So first part deals with the importance of pain. Like, pain is terrible lord, even than death itself, and pain relief is most important responsibility of the society. So she has authorized shifted the burden on the society, and if it is done, it reflects the quality of sensitivity by the society. Specialist pain clinics are norm, right? They are in routine practice in developed countries, not in developing countries. She says 15 to 20% population has acute pain, 25 to 30% has chronic pain. So this is, she is telling prevalence, not incidence, prevalence. It affects the quality of life, and it has economic and social consequences. And she is quoting many quotes like, for the all happiness man can gain is not the pleasure but rest from pain. So goal of life is not sometimes pleasure, but to avoid misery. Acute pain is different because after acute pain it is completely subsided and you can forget it, but chronic pain you can't forget it. And pain is not a symptom, another quote, it is an aggressive disease, and this disease damages the nervous system, and this pain is purposeless, it is causing further damage. The mechanism has gone wrong and it acquires neuropathic pain. So there is no purpose in chronic pain. Acute pain has a purpose, but chronic pain has no purpose. Two broader classifications are cancer pain and chronic non-malignant pain. Most invariable feature is relentless constancy. So the most striking feature of the chronic pain is continuous pain. So chronic pain is chronic continuous pain. It might change in intensity, but it never stops. Then mild, moderate pain and severe pain, she has graded them. She has given examples like backache, failed back syndrome, neuralgias, neuropathies, RSDs. I don't know what is it. Then acute pain has an organic cause and amenable to traditional treatment. But chronic pain is enigmatic. Enigmatic means it has no discernible cause. There are no treatable organic causes, and then patient and doctor feels that it is all in their head. Patient gets confused and depressed, and patient tries to find out right doctor who will understand him or her and pay attention to her. So pain clinic is where all kinds of pain people come. There can be multiple etiologies or varied etiologies, medical, surgical, orthopedic, trauma, onco, etc. Though conditions treated are cancer pain and non-cancer pain, and treatment are varied as the etiology. Chronic non-malignant pain syndrome she has enumerated like chronic back pain with radiculopathy, acute herpes, post-herpetic pain, neuralgia, peripheral neuropathy, facial pains, headaches, central pain syndrome, phantom limb, chronic pelvic pain of females, myofascial pain syndromes, and unusual pain condition like HIV, etc. And previously we used to rely on older blind techniques of nerve localization, but currently we have to imply on imaging using dyes for exact nerve localization, then electrical and ultrasound guidance for localizing the nerves exactly, and then using continuous blocks plexus or nerve blocks to replace repetitive intermittent block. These continuous blocks have a healing effect. Then other modalities have to be joined like radiofrequency ablation, intrathecal long-term pump, then spinal cord stimulators, then these all techniques they do not mutilate the nerve and damage them. These neurolytic blocks like uh, phenols and all, these phenols and alcohol, they are widely available. They are mutilating and cause neuropathic pain. So modern pain relief pain clinic is again multidisciplinary. You need a physical therapist, you need a psychologist to teach them coping techniques. So other advances in pain management, like she has mentioned this, that you have to exactly localize the nerve and then use modern techniques. Now she is again telling further few things like pain specialist is a new breed of specialist, interventional pain specialist called as. Then he or she will use fluoroscopy for pinpoint accuracy. There no blind technique which cause indiscriminate destruction. Inject under fluoroscopic guidance. Then exact location is known, and inject ultimate anti-inflammatory drugs like steroids, and these are longer acting, triamcinolone or depomedrol. They have slowly and release it for 2 to 3 months, so it gives nurse time to heal for that time. And safer techniques are radio frequency ablation, no neurolytic techniques. These techniques give neuropathic pain. This graph is good. It summarizes, images blur. At pain sensor, you have trigger point injections and Botox. At nerves, you have sympathetic block or continuous plexus block. At spinal cord, you have intrathecal pump or spinal cord stimulators. At limbic, you have counseling and mediation. Again, she is enumerating like implants, spinal cord stimulators are of very use. Then intrathecal pump she has shown. This is intrathecal inside the CSF. The cord is taken out. Then there is a pump kept inside the subcute in abdomen, and this is a remote which will adjust the rate. So the total system is inside the body. Cord is final common pathway. Catheter is placed inside the intrathecal space. Pouch in front of the abdomen. Then preservative-free buprenorphine, Baclo, Midas or clonidine is used and since drug is very close to spinal cord, you need very small doses, and that's why it has very minimal or nil side effects. And it will need refilling every 2 to 6 months, and that also can be done through specialized port. This total system can go long for 5-7 years. The only issue is that you have to change battery after 5-7 years, and it is the most accepted treatment worldwide. It's intrathecal pump, and it has analgesia without sensory effect. The only issue is that cost is very high, so if person is not willing to bear, then you can put epidural. She has told intrathecal, now she is saying other option is in epidural. Then other new modalities are like discography, which pinpoints the intervertebral disc to be removed. Then there are two special processes like IDET and nucleoplasty. These are she comparing with angioplasty, which has replaced the cardiac surgery. IDET is intradiscal electrothermal annuloplasty. It is used for backache without disc prolapse. So it is intrathermal ablation. And then there is nucleoplasty, which is ablation of prolapsed intervertebral disc, small size intervertebral disc which are presenting as radiculopathy, neurological pain. So these two modalities. So she has mentioned newer things like fluoroscopic guidance, then dye for localization, then long-term steroids, then radiofrequency ablation, then implants, intrathecal epidural pumps, then IDET and nucleoplasty. So the author has used them, and she is advocating such newer advances to be dealt in the pain clinic setup. Now she is telling about universal problems and peculiar problems to our country. So, universal problem. It is a one specialist approaching the multifaceted problems. So she is saying that will not work. You need a team. As you saw, you need physical therapist, you need psychotherapist. For anesthesiologists, some are advantage, some are disadvantage. We'll see the advantages first. Pain and nerves are familiar territory to the anesthetist. Uh, he has knowledge of pain pathways and other drugs used, and he has knowledge of resuscitation if things go wrong, and he has familiarity with neuraxial and peripheral nerves, and since he is continuing seeing the surgeries and all, he can take a next step of performing the surgery. The limitation of anesthesiologist is he is not familiar with imaging, he is not familiar with chronic pain conditions. Anesthesiologist by definition deals with acute post-op pain only, which is highly amenable with drugs in seconds or minutes. So he is not accustomed to waiting for days for drug to act in chronic pain. And varieties of etiology of pain. Pain is multifaceted, multi-etiology, and it goes into medical domain totally. So you will need another 18 hours of daily study. So again you have to enter the residency. She is saying that you will need a continual medical education. Then anesthesiologist has a habit of being behind at the scene, but now you have to come in front, but this will require maturity, philosophy and spirituality, a detached but involved attitude, because you will get exposed to the miseries of the life, and again you will get success also, so you will get adulation. So both things you have to match. Problem particular with our country is that vital analgesics are not available, especially in preservative form. She has mentioned all the examples. Then medical legalities of achieving them, using them. Then there are bureaucratic hurdles of procuring opioids, licensing them, transporting them. Then there are short expiries. After that, you have to officially destruct the unused drugs. Then pharmaceutical companies are not interested because demand is low, so it is not lucrative. No money is generated, and pain specialists are not more. Profit is less. This is a new branch, so no one is interested. There is lack of awareness even in medical field, as pain is new and different specialty like CRPS 1 and 2. Medical insurances don't cover it, and it will backfire. They will say you had already a surgery or complaint, so we will not finance your this pain therapy because you were pain free between, but you had some precipitating factor previously, so that nullifies that you had a disease, so we will not pay you. The problems of private practice, it is very difficult to set up, so it can be demoralizing and unproductive effort. You have seen all these complexities. uh, Finance is major issue. There is not much of remuneration, patient is already exhausted, so you will feel pity and you will only have to mobilize money for them. And anesthesia has greater earnings than pain clinic initially, so you earn nominally initially and it is not uh, sustainable, but as you grow famous and you get results, then it will become rewarding. She has not mentioned the reward is mm, monetary or moral, but it appears to be both. Most mandatory prerequisite, continuing education. You need to study continually, and if it is, that is possible only if you work full time as pain specialist. And to work at the full time level, you need to practice anesthesia for a few years, so that you develop contacts, you develop good wishes of seniors, and you develop equanimity of mind to uh, get adjusted with the success also. So that is maturity to handle adulation. And you can initially you can form a group practice, or you can get attached to hospital. She is giving some hacks or initial setups. You can try for visibility for references. You will need a good library, you will need a OPD, OT, and image facility. So these in hospital setup can be done. If you go on setting it on your own, then you will be having tension to pay loans. So rather than doing it, you loan the facility or work somewhere else. Opioid licenses are an issue. I couldn't understand the English in this para only. And if you get attached to hospital, you will get better credibility. Medico legal problems also, institute will finance you. And you have to the team approach, like she has already said. um, you have to understand the limits of your practice. You have to accept alternative medicines like acupuncture. Acupuncture, if you read on Wikipedia, it says it is bogus. So she's justifying it that it is not bogus, it works. And there are English counterparts, means physio, it is labeled alternatively like intramuscular stimulation. So by that way you can make it acceptable. You need improvisation to use plexus block to make them into continuous. Then there is paucity of published material. Then there are no guidelines. Western journals do not accept Indian authors things because they are not willing to put faith. And acupuncture, she has again said it here. Here it is example of Sudeck after Kohli's fracture fixation. Then she has applied continuous brachial plexus block for 40 days and then it is resolved. She has given a positive example. Then after hernioplasty, patient has pain, so she did continuous lumbar plexus block, but still it was some residual, so she has done 3 sessions of IMS, intramuscular needling. So it is क्या बोलते हैं vista of her patients. And then there are no statistics, no journals, no statistics in Indian experiences. um, she is happy about the interventions, that it cuts down the cost. And Indians, they have ethnic aversions to medicines. They feel we should not be dependent on medicines and they resent on it. And it goes on, so intervention is easier. So concluding, she has said pain practice in India is possible if you treat every hurdle as a challenge.